So once again, good afternoon, ladies and gentlemen. Welcome you to AIOC, where we are live from Hall Kelvin. So moving on to our next session, I would like to invite a chairperson, that is Dr. Ashish Sharma from Coimbatore. I request Dr. Ashish Sharma to take over the session again. Thank you so much.
Okay, so good afternoon to each and everyone, and I am Dr. Ashish Sharma, and I am the chief instructor for this course, and I have excellent faculty members and the co-instructors who do not need any introduction. Dr. Raja Narayanan, who would probably be joining in a minute, he's from LV Prasad Eye Institute, and Dr. Natarajan, he doesn't need any introduction, he's from Aditya Jodh Eye Institute. And a very young and the dynamic faculty who was my student right now working in Ayodhya, Dr. Nilesh Kumar is with us. So the reason behind organizing this session was in the recent past, if you know, there are anti-VEGF molecules, a lot of innovator anti-VEGF molecules have come into play into the clinical armamentarium, but there is a roadblock because of the inflammation, higher rates of inflammation. And if you look at the Abicipar was denied FDA approval because of the higher rate of inflammation. And even if brolucizumab, if you see, we are battling with a newer kind of inflammatory trait. And even faricimab, if you look at the data, it looks quite promising with the chances of inflammation quite low, but still it is approximately 2.5%, which is higher than what we are using as of now. So this is all about immunogenicity. We feel that this is an important area that we should all discuss, understand, because there are a lot of things which are still, still a kind of have dots which still need to be connected. So we have excellent panel of speakers, and we will be discussing immunogenicity in detail, including all the anti-VEGFs, biosimilars, etc. So without further delay, I would like to call upon our first speaker, Nilesh Kumar, and I would request all the speakers to stick on time, and we would be taking, I don't think we have any questions, but we would discuss amongst ourselves at the end of the session. Thank you so much, and I request everyone to be muted and the video off once the speaker is speaking. Thank you so much. And Nilesh is going to speak about the basic understanding of immunogenicity in the eye. Nilesh, please go ahead.
Thank you. Thank you, sir. Thank you so much. A big thanks to AIOS Scientific Committee for conducting this event, and Dr. Ashish Sharma, sir, my mentor, for giving me this opportunity. I'm Dr. Nilesh Kumar, and I'm here to talk about understanding the immunogenicity in the eye. These are my financial disclosures. We already know that immune response is a sequence of molecular and cellular events intended to get the host rid of threat, offending pathogenic organism, toxic substance, cellular debris, or neoplastic cell, which may be an innate or adaptive response. Inflammatory response, theoretically, is just the clinically evident immune response. The understanding of ocular immune privilege, which means the loss of immune response in the eye on routine basis, has evolved over time. First described in 1950 by Medawer, he described the immunological ignorance to be based on passive mechanisms such as blood-ocular barrier and lack of lymphatics. Kaplan and Stirlin in 1977-78 described the immunization through anterior chamber, which created systemic deviant immune reaction, which were deficient of cell-mediated immune reaction. That is the point to be noted, that cell-mediated immune reaction was deficient in those reactions. The current understanding says that the immune privilege is an anatomical segregation and a complex interplay of other active mechanisms. These active components include immunological ignorance, peripheral tolerance of eye-derived antigens, and the immunosuppressive microenvironment in the eye. The passive components include blood-ocular barrier, deficient lymphatic drainage, intravenous aqueous humor drainage, the reduced intraocular expression of MHC class 1 and class 2 molecules, and a fewer antigen-presenting cells, while the active component includes several cell surface expression of CD95, 46, 55, 59, and other soluble factors which create the immunosuppressive environment, that is the TGF-beta, alpha, MSH, VIP, and similar cytokines. So innate immunity is an antigen-independent reaction having immediate maximal response, which is not antigen-specific, and there is no immunological memory. These are delivered by lactoferrin, isozymes, defensins, complement, mannose-binding lectins, and other toll-like receptors expressed on the cell surface. In contrast, adaptive immunity requires antigen, which has to be recognized by the immune system. This antigen is recognized by the presence of their epitopes, which is then processed by the system, and then there is an immune reaction which can be delayed too. This reaction is antigen specific, and the immune system creates a memory of that particular antigen. So the reaction that happens in response of adaptive immunity has 4 mechanisms. Type 1 or anaphylaxis reaction is an IgE mediated immediate reaction, while type 2 reaction is performed by cytotoxic cells via IgM or IgG or IgM antibodies, and that can happen within few hours to few days. The other type of reaction we will see in subsequent slides in more details. So immune response, that is the adaptive immune response, can also be divided apart from the types into 2. Humoral, that is antibody mediated response, and cellular, that is cell mediated response. So humoral response is via antibodies produced by B cells targeting extracellular microbes and their toxins, which are recognized by B cell receptors. Those can recognize also the unprocessed antigen, so they don't require an antigen presenting cell. In contrast, the cellular response is via specific T cells responding to intracellular microbe, their byproducts, and tumor cells via T cell receptors. These receptors need a processed antigen to be presented to them. Now, the point to be noted is ocular resident cells have majority of very primitive antigen presenting cell that can't process the antigens as good as in other parts of the body. So type 3 hypersensitivity reaction is a humoral response involving IgG antibodies, which form chains with the antigens and they get deposited in the tissue. These deposits attract complement that leads to neutrophil discharge. This complete process may take from few weeks to several weeks to become clinically evident or to call it as inflammation. In contrast, type 4 reaction is a cellular response where the antigen are captured by the antigen presenting cells, which migrate to the lymph node to form specific T cells. The CD4 T lymphocyte are the T helper cells, while the CD8 cells that recognize the antigen on somatic cells are cytotoxic T cells to kill them. The T helper cells then secrete mediators such as interferon gamma and TNF, leading to the granuloma formation. The formation of cells in lymph node after the first exposure is required, and the second exposure will lead to a rapid response via that specific TH cell. This total thing can take up to 6 to 8 weeks to be clinically evident, and thus has been termed as delayed hypersensitivity reaction. So that is the confusion that happens that if the patient is presenting late, they tend to say that it is a delayed reaction, but it can be an immune reaction via type 3 also, which has taken some time to become clinically evident. So how does these antigens escape eye? The antigens can leave eye via these 4 gates. That is the lymph vessel of conjunctiva, anterior chamber angle and Schlem's canal, the retinal venous circulation, and the choriocapillaries. All this drainage goes to the spleen, which is called as the lymph node of the eye. All the reaction that takes place, cellular reaction and the maturation of antigen presenting cell and the sensitization of T cell all happens in spleen. And any antigen presenting cell to initiate T cell maturation should reach the spleen. The peripheral tolerance to the antigen from the eye occur there because of the loss of immune reaction to such antigens. Any cross reactivity thus has also an impact on the splenic phase. Let us understand some part of the sources of immunogenicity, while Dr. Ashish Sharma will be dealing with it in more details in his talk. First thing to understand is why does not all the injected biologics, which are essentially foreign or non-self, induce an immune reaction. This is done by making the antibodies more humanized, essentially leaving the epitope section non-human. These humanized antibodies are tolerated by our immune system, similar to that self-antigen tolerance pathway. The molecule, however humanized, still are all immunogenic. The vehicle itself can carry cellular debris, degraded protein fragments due to oxidation or deamidation, and aggregation of such protein debris, and they can also carry endotoxins from the producer's cell line. The injection technique itself can cause a reaction. Details of each component, I think, will be dealt by Dr. Ashish sir. The immune reaction can be enhanced by localization and prolonged presence of the biologic in an increased concentration in the proximity of antigen presenting cell, and such factors may lead to inflammation. The antigen site on the antibodies have been termed as idiotopes, and these antibodies produced in response to such idiotopes are called as anti-idiotope antibodies. And when they are produced in response to a therapeutic biologic, it is called as anti-drug antibodies, or ADAs. These ADAs are mainly directed for the feedback inhibition to reduce the effect of the antibodies. The ADA produced via T-cell dependent pathway if the biologic is processed by antigen presenting cell, while few can directly interact with B cell to convert B cells into IgG producing plasma cells. The IgG ADA development can be triggered by an exogenous human protein or by failure of immune tolerance to the self antigens, as it happens in neovascular AMD, that can lead to an overt immune reaction. The ADAs can be either binding or neutralizing. The binding and ADAs bind to the non-active site of the antibodies, and it can either reduce or enhance the systemic clearance. While neutralizing antibodies, neutralizing ADAs bind to the epitopes to neutralize the therapeutic property of the biologic. Treatment emergent ADA are new crop of ADA that are secreted in response to the new biologic therapy and can either be binding or neutralizing, or can be a mix of both. The Ig1 and G2 antibodies are majorly of binding type, while G4 are majorly of neutralizing type. New immunological debate has been brought into focus due to retinal occlusive vasculitis, which has been reported following brolucizumab. While there have been many theories put forward about the pathway, including our group, the only clinical pathological correlation was done from the vitreous sample taken from a patient which shows majorly CD3 positive cells that are immature T cells. There are also some CD4 and CD8 cells and some rare B cells. The work from Sterling et al. Has shown that B cell production is suppressed in the eye, while there is some amount of CD8 cell being produced normally. So presence of B cells and CD4 cells indicate that there is probably some amount of humoral response involving the ADAs. The rest will be dealt by Dr. Ashish sir in his subsequent talk. Thank you, sir, for this opportunity.
Thank you, Nilesh, for the as far as immunogenicity is concerned. So we would be, and I think Dr. Raja is here. Hi, Dr. Raja. So Dr. Raja would be enlightening us on how you differentiate infection and inflammation, and context of what kind of inflammation that we have seen with other anti-VEGFs are we heading to. So Raja, please take over.
Yeah, thank you so much, Ashish. First of all, I would like to congratulate Ashish and Nilesh for the wonderful work that they've been doing in this field. And thanks to Ashish for this invitation. I'll be talking on immunogenic reaction, how to differentiate infections from non-infectious inflammation. Overall, I would say this is a broadly well-known topic, but still I'll go through the various features which can be seen in inflammation. You can have vitritis, iritis, hypopion, or retinal hemorrhages, or vasculitis. And these could be non-infective also, and it becomes very crucial to differentiate it from endophthalmitis. So these are the different types of inflammation which one can see. As you can see on the bottom right, you sometimes there may be frank endophthalmitis, and you should not be delaying treatment with antibiotics in these cases. Whereas in the others, you may want to give oral or topical steroids, and they can manage them very easily. But just to go back, inflammation after biologics, or specifically intravitreal injections, is not new. It has, at least in India, we have known or dealt with this episode in 2016 when there was a ban on Avastin by DCGI, and then later on it was reversed. But it could be severe inflammation due to various factors that Nilesh had pointed out. It could be because of the drug itself, it could be because of various other solvents, pH stabilizers, or it could be a frank contamination due to spurious drugs, as was in this case. Now, spurious Avastin is not unknown. It has been seen in China in 2010. It was there in the US too. It's been seen in Turkey. So in China, there were more than 100 patients in 2010 who had non-infectious reaction due to counterfeit Avastin. And we need to be careful whenever there are higher incidents. There usually the societies or organizations raise an alert, and we need to be cognizant of those before we take a call whether it's an inflammatory reaction or whether it's uh, an infectious pathology. Even Razumab from Intas, which is ranibizumab biosimilar, in their reenact studies, they did not find any adverse reaction. As you can see here, no patient had any evidence of anterior chamber or vitreous inflammation, but it can vary from batch to batch. So what you have in the trial one, it's a small sample size, the batch will be different, but then your manufacturing practices may not be always streamlined. So another batch may produce some inflammation. So we had a situation where we had to issue alert for adverse reactions after Razumab. And now recently in brolucizumab, the Hawk and Harrier trials had shown some of the reactions, but there were no serious reaction of CRO or even vitritis noted in the Hawk trial. But in the post-hoc analysis, once this was came up after the post-marketing surveillance, the safety review committee of ASRS looked at all the data and found the incidence of intraocular inflammation to be 4.6%, which is much higher than what was actually reported in the original trial of Hawk and Harrier. So now in the Merlin study, and there were other studies, Raven and Raptor, which have been discontinued, the intraocular inflammation was almost double the rate of inflammation in the control arm of aflibercept. As you can see here on the top, brolucizumab 6 milligram at 9.3% inflammation compared to aflibercept, which had 4.5% inflammation. And CRO is something which is seen probably only with brolucizumab. So these are the important things which we should be aware of, and a decision has been made. Basically, Q4-week administration has been terminated for brolucizumab. It's not advised to give Paginax or BOVU every 4 weeks. Now, coming back to these inflammatory signs versus infectious signs, in inflammation, generally you don't have lid edema, there is no chemosis or discharge. Hypopion may or may not be present, but in general, if there is hypopion, you must actually rule out infection in such cases. Fibrin and AC also, it may point to an early intervention in terms of infectious etiology. B-scan probably may not be that effective in ruling out infectious versus non-infectious etiology. This is courtesy the American Academy of Ophthalmology, Journal of Ophthalmology from Baumal et al. You see this occlusive vasculitis, there are skip lesions, there can be Kyrillis arteritis, there can be occlusion causing infarcts of the retina. And these patients can have severe loss of vision, and it can be in a skip format. Then you have this frank endophthalmitis patient presenting with severe hypopion, exudation, fibrin, and ultrasound can also show a lot of exudates in infectious endophthalmitis. But again, as I said, ultrasound cannot rule out infection. You still have to go by the clinical signs. This was one of my patients, one of the earliest patients which I had managed with Paginax or brolucizumab. This is day 1 after the injection, which is extremely uncommon to see this kind of severe immunogenic inflammation. As Nilesh pointed out, and Ashish probably will also elaborate on this, most of the inflammatory events in brolucizumab happen after the 2nd or 3rd week, and also after the 2nd or 3rd dose of brolucizumab. But this patient had presented on the 1st day, and it was the first injection of brolucizumab in this patient. But this patient had multiple other anti-VEGF injections before this. And this patient also had hypopion. But this patient, when we did the vitreous lavage and and the vitreous tap and intravitreal antibiotics, there was no growth on microbiology. PCR was negative, gram strain was negative, and this patient improved within 3 days. The fundus cleared on topical and steroids. So inflammation can be really, really difficult to manage in some of these cases. In terms of management, what I follow is if there is mild inflammation and these are known drugs which can cause inflammation, I use frequent topical steroids for a few days and ask them to come back. If it's a severe inflammation, definitely if it is with known drugs like razumab or brolucizumab or even aflibercept, you give frequent topical oral steroids, call them the next day. If there is no improvement, you do a vitreous tap and antibiotics or a vitrectomy depending on the severity. And if there is severe inflammation with lid edema, don't take any chances. Do an immediate vitrectomy with antibiotics. So in conclusion, there should be high suspicion of inflammation. You should be aware of the drugs. Slit lamp evaluation at every visit is mandatory. Even pre-injection, look at the AC and vitreous cells, which retina specialists do not tend to do. Immediate versus delayed, in the sense delayed, it could be inflammation, but my case had immediate inflammation also. But it's better to rule out infection in severe cases of inflammation and take immediate action. Thank you for your kind attention.
Thank you, Dr. Raja, for enlightening us with that excellent talk and again, re-emphasizing that how important the pre-injection evaluation is. So we would be discussing at the end of the session. So next is my talk. I'm unable to upload. If somebody can help us.
So your presentation is visible. Yeah.
Oh, thanks, Tanvi.
Yeah.
So good afternoon. So I would be talking about the understanding the sources of immunogenicity. I think we have a little bit of overlap with all the speakers, but that's justifiable because we cannot be really on the borderline. So I would be especially discussing about what kind of sources we can have which can cause immunogenicity. So okay, so we have been trying to understand immunogenicity since last couple of years, and this is our content. I would definitely like to acknowledge all of them, and I would like to acknowledge especially, am I audible? My internet connection says unstable.
Yes,
You're audible. You're audible.
Okay. So I would especially would like to acknowledge couple of two of my residents who have done phenomenal work with me since last 2 years and helped us with understanding this phenomena in great detail, Dr. Nilesh Kumar and Dr. Nicola Parachuri. So these are my financial disclosures, and regarding the sources, there could be a few things. For example, procedure related, syringe related, and if you talk about the drug per se, you can have endotoxin, molecule itself, or probably both. Procedure related means, I think since last 10 years, we have been giving intravitreal injections. So we know that what kind of injection settings are safe and what kind of injection settings are unsafe. And as Raja mentioned, bevacizumab was blamed not because of the drug, but because aliquot process was a problem. So in developing countries, this was predominantly an issue. It still is an issue, but not in the developed world. If we talk about the syringe related, this is the editorial that we published last couple of years before, when Allergan had done a temporary stop on the Ozurdex injection because they found during their R&D there was some particles seen. Although silicone doesn't cause immunogenic reaction, but because it was seen, so it was noted. And when we went back, this phenomena was there for quite some time. And Dr. Bailey Froon, he noticed it when it was noticed first time with the syringes. So we brought down this again, and what has happened was this could be related to few things. For example, silicone coating on the syringe and the needle, which is required for the smooth plunger movement and to make the procedure painless. And there is a possible interaction of biologics with the coating, along with sometimes we tap on the syringe too much, and if the silicone can detect. It doesn't cause immunogenicity per se, but it causes floaters, unnecessary floaters. Now, what is the way forward? Now you have non-siliconized syringes available, especially in the developed world, but because of the poor cost effectiveness, they are not really universal as a siliconized syringe as of now. Then I would come to the drug-related complication. This is the paper that we published, as Raja mentioned, initially with few batches. Razumab showed reaction. And the reaction, when they went back and tried to understand that why they had those reactions, then they found that it was the problem of endotoxin levels. And the endotoxin levels was pretty high. And actually, if you look at the FDA do not differentiate anterior and the posterior chamber endotoxin limits. Anterior chamber, so whatever we do in ophthalmology setting, it's all about the endotoxin in the anterior chamber. So there is no clear recommendations of the posterior chamber endotoxin limit. So once they reduced the endotoxin limit, and the reason was the buffer. So whenever you have an endotoxin phenomena, then you have immediate immunogenic response, which was seen with Razumab. And these are the issues which are predominantly related to the excipient or the process. And this problem of endotoxin can be controlled, which was done by INTAS, and over the time they have no immunogenic issues. So these are a couple of papers we highlighted that what we think about the endotoxin and how it affects, and there is an inherent tendency of any biologics, to have this because of the complicated process of manufacturing. Now, these are a couple of papers that we published when brolucizumab was launched, because brolucizumab, Novartis has done their homework, and Novartis has clearly mentioned that their processes are fine. There is no excipient issue. There are no preservative issue. So at the end, it bottles down to the molecule itself. So probably still things are very much in gray. Still Novartis has no clue that why that is happening. So the blame goes to the molecular structure. As far as we understood this phenomena, it's difficult to control. And these are a couple of papers, even when the Hawk and Harrier data published, we had a few questions about the design and the comparison. And once the brolucizumab had some signals in even Hawk and Harrier regarding the higher rate of IOI, that also we mentioned in these couple of papers. We got good response, to our satisfaction by Praveen Dugal in terms of the comparison, but still everybody is gray in terms of the immunogenicity aspect. So again, as I told you, this is the recent editorial that we published, that whether it's really a complex phenomena or we have something we can easily understand. As of now, our stand is that it is an ADA, which was found, even in the pre-injections in Hawk and Harrier. So ADA and the type 3, still difficult to understand and difficult to predict whenever it comes to the molecular related immunogenicity. Now, we have been tracking even abicipar since quite some time, and these are the couple of papers that we published even when abicipar passed before in ophthalmology. We had few questions in terms of how the immunogenicity assessment was done. So this is abicipar was a molecule, which was not exactly the classical anti-VEGF platform, but rather it was kind of a DARPin platform, which is slightly different. So here the culprit was the E. coli fragments, because E. coli was used in their process. So initially they had a lot of fragments, but even after filtering the fragments, their immunogenicity was pretty high. So so here both endotoxin and the molecule per se had issue. Am I audible?
Yes, Ashish.
Okay, so means I really like to thank all my residents, and this is our wall. This is an innovation wall, and all these small chapters on immunogenicity, understanding. I would really like to thank all my residents, who have put up a lot of efforts and published this data, and each and every frame, in my institute, it tells about their hard work, and they still dream and they keep dreaming. Thank you so much.
Can others mute themselves, please?
Yes, thank you, Raja, for pointing that out. And so now I would like to invite Dr. Natarajan, and he would be talking about that what world can learn in terms of, because India was the first country that approved biosimilar, even when the regulatory is still not clear in the world, that how the biosimilar should have the approval. We recently, I had a communication with the FDA, means one of our paper got rejected recently, but FDA, who was actually evaluating the entire process, he called back us again and saying that, we would really like to contribute and again rectify the paper to really, give the information that how FDA sees biosimilar and how EMA sees biosimilar in terms of the approval process. But India is the first country to give the approval. So there is a lot of lesson to learn, not only for us, but for the entire world. So Dr. Natarajan would highlight on that. It's over to you, Dr. Natarajan. Thank you. Dr. Natarajan, are you there?
Yes, I'm there.
Okay, sir. Can you upload your slides?
Yeah, I'll do that. So you can see the screen?
Yes, sir.
Yeah. So lessons learned from biosimilars. Thanks to Ashish for having me in this session. And I always love to work with Ashish. Financial disclosure, nothing to disclose. Biosimilars, the biology which are similar in structure, efficacy, and safety to the reference molecules. And biosimilars are ought to be similar to biologics in their target protein, their formulation, dosing, and administration. We have a biologic biosimilars and biobetters, different terms or different drugs by Ashish Sharma et al., along with the Francisco and Lowenstein. India leading the way, Razumab, the first approved biosimilar for ophthalmic use, reference molecule ranibizumab. Ranizurel, recently approved second biosimilar to ranibizumab in India, filed for approval to FDA and EMA. And I think even Cipla has come out with a new one. And benefits of biosimilar, shorter development cycle, cheaper R&D cost, reduction of cost of therapy up to 25%, and a further reduction possible as competition increases. Here is the similar design like the biologic and biosimilar. Now, biologic is a novel therapeutic, and biosimilar is competitive bioequivalence, and 15 years to develop a biologic drug, and a biosimilar about 8 to 10 years to develop, and a biologic about $1.2 billion cost, and a biosimilar about $100 to $200 million cost. And biologic is patentable, biosimilar is not patentable. Reference price, and then here biosimilar is the reduced price. So initial hiccups and the exclusive complaints prompt Intas to recall batch of biosimilar. Intas said it is undertaking a detailed analysis on reports of inflammation and has advised doctors to avoid using the product meant to treat an age-related eye condition from this specific batch. And Hyderabad intravitreal injections of batch number 180200052 have been found to cause intraocular inflammation and have been recalled according to patient safety advisory issued by the Vitreoretinal Society of India. And the nocebo effect, the perception of biosimilar being a generic medicine and hence inferior molecule concept was enhanced by the occurrence of ADRs with arozumab. This is a letter to the editor, again by Ashish Sharma et al., where ophthalmic biosimilars lesson from India, published in Indian Journal of Ophthalmology. The corrective measures, the endotoxin levels of arozumab were brought down from the ISI standard before to FDA standard currently. And the incidence rate during initial episode, February 2017, 11 out of 14,265, about 0.07%. And incidence rate during the next episode, February 2019, 7 out of 47,129 is equal to 0.01%. And this is since February 2019, 0%. So the biosimilars action plan, balancing innovation and competition, and rising interest in biosimilars, FDA and other regulatory authorities have initiated educational programs to ward off nocebo effect surrounding biosimilars. Main concern is to fight off financial toxicity of the biologic therapy with the low-cost, efficacious alternatives, and understanding the regulation and a very well-regulated developmental process across the globe. Approval requires robust proof of similarity and efficacy, and the British Journal of Ophthalmology publication, again by Ashish Sharma, Nilesh Kumar, Barry Cooperman, Francisco Bandela, and Annette Lowenstein. Understanding biosimilars and its regulatory aspects across the globe and ophthalmology perspective. Real-world data, first study for biosimilar switch, similar in efficacy, no safety signal, no immunogenic reaction, again published in the Immunogenicity and efficacy after switching from original ranibizumab to a ranibizumab biosimilar, real-world data. And then it also have a strict pharmacovigilance is the key in terms of immunogenicity. This is a publication, Ophthalmic Biosimilars, Lessons from India, 2019, IJO. And then this is the latest one, the in the in 2021, ranibizumab biosimilar, Razumab versus innovator ranibizumab, Lucentis in neovascular ARMD, efficacy and safety, the BIRA study by again Ashish Sharma, Nilesh Kumar, Nicola Parakshari, Francisco Bandela, Barry Cooperman, and Annette Lowenstein. And this is, I think, the latest article. And I think I should appreciate the excellent work done by Ashish Sharma and our Secretary of Veteran Society, Raja Narayanan, and Nilesh Kumari mentioned. And I think the need of the country and the need of the hour for India, I think.
Thank you, Dr. Nagarajan.
Yes.
Thank you very much. Thank you very much. So we have come to the last talk, which I'm going to talk about the brolucizumab and the vasculitis and the occlusive vasculitis per se as a specific phenomena which we have never seen. We would try to understand this phenomena a little bit more in detail. I think we have sufficient time. I might take a little bit more than 10 minutes here because rather than just talking about the brolucizumab and vasculitis, I would just try to talk about a little bit in the background, because we have been covering this molecule and trying to understand this molecule since last 2 years. So it is kind of a story for us actually, that how and it's a wonderful story. There's a lot of learning as far as this molecule, the way the processes are done and the way the rebuttal. So a lot of learning from this story. So again, this is our contribution in the form of publications. And again, the same group I would like to highlight. All of them, and especially a lot of hard work has went through these two of the DNB residents. Am I audible? My connection says unstable.
Yes, Doctor, you're audible. Yeah.
Okay. Thank you. So these are my financial disclosures, and so brolucizumab, when even launched, when we saw the brolucizumab, what kind of molecule it is, it was a structural revolution. We were all in initial phases of a study And that was the time we were excited. And this was the first paper that we published, that brolucizumab is kind of a leading an era of a structural revolution for long-term VEGF suppression. And why it was a structural revolution, I would say, because it was the smallest molecule, not only in the ophthalmology, but it was the smallest molecule what exactly, it compares with what we have in our armamentarium at this point, what we use at this point. If you look at the bevacizumab is our microbiology and MBBS, that you have a FC portion, you have FAB arm, and that's where it's, kind of a big size molecule with a light and the heavy chain. Similarly, if you look at the aflibercept, although it had a decoy receptor, I'm not going into the detail of that, but what I'm trying to highlight here is it also had FC portion. The importance of FC portion is that it provides any kind of molecule. But if you look at ranibizumab was kind of a cutoff from the FAB part, and it was lacking FC portion. FC portion had some immunogenic responses also, but overall stability is the main function of FC portion. And if you look at brolucizumab is further small. Now the question arises, such a tiny molecule without having FC portion, how can it be stable? So to stabilize it, it had a kind of a nice chain, a protein chain, which was stabilizing it. Now, next question that somebody should ask is, that's what we asked, that what structural revolution other way around to do some adverse events also, but science has to evolve. So what structural evolution and a small molecule could achieve was better penetration in the retinal layers, easily understandable because smaller molecule it can retinal layers, which was proven in the baseline studies of brolucizumab that it was 2.2 times more diffusible if you compare with the Lucentis. And on the other hand, it's, you can understand easily that more molecules you can pack in a similar dose. So actually you can pack 20 molecule, it can have a faster exit from the systemic circulation. So chances of even systemic adverse events could be less. But this was all, when the structure was being designed, and that's where we published these couple of papers. Because of the smaller structures with the packed doses, it could have an extended suppression. And again, we published another paper that is just an anti-VEGF or beyond, because it was, it was kind of different from the other anti-VEGF in terms of the penetration deep into the retina. And so our excitement continued, and as soon as we saw that Hawk and Harrier results are announced, and it showed it had a greater efficacy and equal safety. But we had few questions in terms of the design of the study when it was the way with the aflibercept. So because aflibercept was tested 12 weekly, however, brolucizumab was allowed to switch between. And even another aspect was that why from CFT to BCV after 16 weeks, but nonetheless were answered very well by Dr. Praveen Dugal, who was heading the trial. After this, we to simplify this information for physicians, we had published these couple of papers. So what are the key learnings from Hawk and Harrier, and what is the kind of impact on fluid that brolucizumab had. And the day came on October 8, 2019, when Novartis received FDA approval from the in the form of BV. Is approved as patient next because of some kind of pricing structure. Then after that, few months, on 23rd Feb 2020, ASR vasculitis were reported, And out of those 14 cases of vasculitis, 11 were vasculitis, which was never seen with any other anti-VEGF drugs in the past. So that was kind of alert, and because it lost their eyes, so it was kind of vision-threatening inflammatory eye condition. Novartis immediately took a step. We should thank Novartis for that, and they formed external SRC. What SRC had, because the drug had only 3 months or 4 months after the SRC, what it could do was it could again call back the cases who were reported as an IOI from the Hawk and Harrier studies, and then they tried to again assess those cases. And when SRC submitted their report in June 2020, what they found was incidence of IOI was quite similar to what was seen in the trial. But retinal vasculitis, retinal vascular occlusion was much higher than what was seen in the trial. Incidence of retinal vasculitis was 3.3% and retinal vascular occlusion was 2.1%. So then Novartis updated. So if you look at the label, which was there in 2019, you would not find any mention of retinal vasculitis and retinal vascular occlusion. However, if you look at the June 2020, on the warning of the label, it was included. So clear disconnect from the real world. And at the same time, we were getting some data from abicipar also. So, we highlighted this drug, that there is kind of disconnect from the real world and the trial. And now, just for the information, although Raja has shown some of the cases, but means again, I'll go back to the same paper by our good friend Carol as a occlusion or a vasculitis phenomena. If you look at the picture A is a pre-brolucizumab injection, and the OCT, if you see, a lot of fluid, subretinal fluid is there. In C, if you look at, there's a whitening, but if you look at, the impact on fluid is quite dramatic. Even this ischemia developed, but drug was working. And in the E, if you look at the E, it is a optos picture, so you cannot see much details, but still you can see on the yellow arrow, the kind of phlebitic sign, and it is very well visible in all and the ischemia. Again, another picture, you can see very clearly visible a lot of occlusions at multiple levels. And this was a patient, who was given bilateral brolucizumab. Initial stage, if you look at that, there are tiny hemorrhages of vasculitis and on the periphery, but after some time, both the eyes, they went into the hemorrhagic vasculitis. And am I audible?
Yes, sir.
Yes, Ashish.
Okay, and this was the kind of presentation with the IOI with retinal vasculitis. You can see with white arrows, multiple all across. Again, here, if you see, there's a yellow arrow where you can see the vascular thickening, and on the nasal side, the sclerosis on FFA shows staining and the ischemia. So now, after seeing all this, after that voice of a retinal legend, Dr. Phil Rosenfeld, I was fortunate to be a part of his training institute at one point of time. He wrote an editorial in American Journal of Ophthalmology with a title that is this a 737 max moment. So what exactly he meant by 737 max moment, I'm not sure if everybody is aware about this. Just for the people who are not aware about this, 737 MAX was a plane which was, a kind of a superior design of 737, and in terms of its capacity in various aspects. So, but as soon as it started flying, initial 2 flight crashed and it killed 346 passengers. And then the 737 MAX plane was grounded for 2 years and it started flying back again in October 2020. So that's how the brolucizumab was compared. And what he recommended, I love this slide. I love this interaction. If you look at the interaction between, Dr. Phil Rosenfeld and Dr. Dirk Saur, for if some residents are listening my talk, I would request them to go and read about inspirational personality. He is a person who was a man. He's the person who has designed brolucizumab. So in the editorial, what Rosenfeld wrote was that can fly again? Can we have a temporary moratorium on this drug? But then Dirk Saur replied that, it's the physician's choice, because, he felt that the drug still has important role to be fit in the practice of retina. But again, because Dr. Rosenfeld, he was not convinced, and look at his statement at the end, that how many more patients need to lose vision before the moratorium is implemented on brolucizumab. So means this is a learning, how you communicate, how the industry leader communicate, and how as a physician, we should really be toward the safety of our patients. Still, what happened? 60 countries as of now for the management of neovascular AMD. And after this event, and we had this editorial in British Journal of Ophthalmology for brolucizumab. We highlighted a few points that how, things in terms of the safety, how we can have better safety measures for the patients. And that was the time when, am I audible? Am I audible?
Yes,
You're audible.
Okay. So then that was the time in February 2020 when the approval was given by the DGCI in India. And I know my country, sometimes what happens, people and the physicians, retinal physicians, are not aware what is happening in the background. Sometimes, because they are busy in clinics. So I wanted to bring this information and wanted to take help before we offer this drug to our patients in India. So we organized a global symposium on brolucizumab in February 2020, exactly the same time when it was launched in India, with the help of leading experts who had, most of them were from the United States, Dr. Thomas Albini from Baskin Palmer, Dr. Kwan from Stanford, and Dr. Vaishali from here, so that to understand, and Dr. Cooperman, my mentor, to understand that how to go about it in India. Discussion and the symposium outcome came in the form of a mitigation plan. Now, there was a mitigation plan proposed by Caroline. And what Caroline did was, if in case any patient develops vasculitis or IOI, how to manage those patients. That was the mitigation plan proposed by Caroline. But Caroline mitigation plan was not involving how to choose the patients and how you follow up those patients. And after this symposium, with the help of all these experts from entire globe, we have published a brave, safe recommendations right from the choosing patients, how you choose the patient, and if some patient develops inflammation, how to manage them. And that was the time when nobody had the real world data. Although, I never used even a single brolucizumab till now, even that time also, but I wanted to bring the real world data to see, what is happening. So then we try to collaborate with all the people in the United States, all the clinicians in the United States who were using this drug. And we brought this publication, first real world data study, BREW study. And what we found was it was very efficacious drug. As you must have seen in all my slides of the Caroline paper, where even the vasculitis was there, but drug was fantastically efficacious. And in our study, we could not find any adverse event, but I would not take it that because it was a too small data, and to find out an adverse event, which is too small in percentage, you need to have a real, big sample size, which we didn't have. So our power to detect adverse event was not enough in this study. So retinal vasculitis and retinal vascular occlusion, it was and it is a mystery for us and for the industry also. So what we propose, because further less, so other than brolucizumab, we were simultaneously working on the biosimilar. So biosimilar is kind of, we published some of the data when to understand the biosimilar leading to some of the immunogenic phenomena in the beginning. So it is kind of, we had some of the old stacks of wine papers, old stack of papers. So when sometimes, old wine gives you some information that is more tasty. So we turned back the clock. We went back to our papers, which we published in terms of to understand the biosimilars. So what we published in 2019, even when the brolucizumab.
I'm sorry to interrupt Dr. Ashish Sharma, but I guess we are running short of time, and there are a few more doctors.
We have 20 minutes of discussion, so we can cut short that one.
Yes, but there are some two doctors who have just texted you in the chat that they have to leave in 2 minutes.
Yeah, no, Ashish, I have to go for other session. So can you?
Okay, I will conclude that as quickly as possible.
Okay.
Thank you so much.
Yes, thank you. So, so basically, we had, we proposed type 3 reaction. We it to Dr. Dirk Shore, and he accepted that yes, pre-injection ADAs were high, and we were opposed by the group from Thomas Albini because they had a vitreous biopsy and they put forth the type 4 reaction because they found those cells in which favor the type 4 reaction. But again, in this editorial, we re-emphasized our stand as the type 3 reaction and the lack of, and we feel that lack of vessel wall analysis was there in the study by the Thomas Albini. And as Dr. Raja mentioned, recently news is that Merlin data is out and brolucizumab has inflammation approximately 9.3%, much higher, and they have completely stopped all the cases, and they are recommending that any case you should not inject brolucizumab less than 8 weeks. What we propose is BioBetter for brolucizumab. The problem is that BioBetter need to go through the entire trials again. So we are tracking this story. That's what we say. The story is not yet finished, and best is yet to come. And thank you for exceeding, and sorry for exceeding the time. Thank you all for joining us. And this is again a great teamwork with the help of my residents and other collaborators. Thank you so much.
Thank you, Chairperson. I would request Chairperson to call upon our next speaker, please.
We do not have any other speaker now. I think that's what the reason to take a little more time.
So I guess there is Dr. Narayan texting in the chat.
No, my talk is over. I gave my presentation.
Yes.
Okay.
So Dr. Raja, do we have time to take some couple of quick questions?
Yeah, sure.
Yes, sir. You can go forward.
Right. Dr. Raja, so now the recent alert by the Merlin trial means, how do you see that?
Yeah, it's a grave concern overall from the perspective of brolucizumab use. It has brought in one more level of alert for all of us. But the only thing is, while in India we don't have any prospective data, reports so far show that the inflammation, at least of serious adverse events after brolucizumab injection, has not been as much as others have reported. But again, it is very early to say that. Our number of patients who have received more than 3 injections is still less than 500. while more than 3,000 injections have been given, very few have received multiple injections. And one good thing in India which happens is very rarely patients get Q4-week dosing, even otherwise. So, and in all presentations so far that I have seen, most doctors, even those who prescribe loading dose with brolucizumab, have not given loading dose very often. That those may be some reasons why we have not seen, but it's still early. But given Merlin, Raptor, Raven, I would say that at this point of time, doctors have to be extremely careful. We know of litigations in other countries. We don't want that kind of a situation. So consenting has to be extremely important. It has to be different from the routine of Avastin, Lucentis, Eccentrix. Your consenting has to be extremely strong going forward if you are going to use brolucizumab.
So Raja, actually, what happened was that if you look at the Novartis now recommendation, that still they are on for the loading doses. Means what they're saying is loading doses are fine, but post-loading doses, you should not have the interval less than 8 weeks. Means somehow I'm not really convinced on that aspect, because as you rightly said, probably, information that we receive from Novartis that India is doing well, probably the reason is the same, that, we are already, expending an interval is pretty high from the beginning. So means what is your take on that at this point? Means
Yeah,
for our...
That's a good question, Ashish. In fact, we had a safety meeting with Novartis India. Our safety committee of VRSI met them when they gave us the details, but this data was lacking as to how many patients during the loading phase itself had this inflammatory events in Merlin or even Raptor and Raven versus those who had after the loading dose phase. So it's something that probably have the data, but at this time they have not looked at it. But all said and done, I would still say that it has worked wonders. As you yourself showed the figures, OCTs can sometimes dramatically dry up in resistant cases. But while it's a wonder drug, we have to be very cautious. We don't want a 737 max moment. But touch wood, in India we have not had, apart from that one case which I showed, my own patient first day severe reaction. We have not had any
I was
exclusive.
completely surprised by your case. Things have happened just next day. Means
Yeah,
that
but now
doesn't...
that patient, this happened more than 6 months ago, and that patient is on, you see, she's been 6 months on Eylea now and no response. So we are talking about going back to brolucizumab, but we are not agreeing to that. So Ashish, I have to log off. I have to go for another call now.
Okay,
Thank you so much.
Thank you so much for to be here, and thank you, Dr. Natarajan, and everybody. Thank you, technical team, for supporting us here.
So the session has been over. Thank you so much, our chairperson, Dr. Ashish Sharma, for enlightening the session. Also the speakers for giving such good information. So we conclude with this session. Thank you so much. Have a nice day again.
Okay, thank you, Tanvi.